send these out to people.
Fine.
This is a nice.
Yeah, I'll take a look at that a little bit more for.
Do teach our families to contact their local fire department to let them know that they have a medically complex child in their home for tornadoes, different outages.
But whether that gets done or not, it's hard to know.
Correct.
Right,
But it
I
would be
don't-
really,
I just know from working on the street, we would get alerts for some adults.
but not so
That
much for
lived
kids.
off of a certain area that was a kind of a frequented problem.
Okay.
Because they didn't have good home care, and so
Okay.
you would respond typically for, G-tube issues,
Okay.
or, hey, I can't reach my water, things like that, and we would have an alert for them, so I wouldn't see that there would be any.
So Amber, is
I
that
can get
something
a
where a
list.
family would reach out to have them put on that CAD or, okay. So that would be
Is
something-
there any way to do it so they need to actually call? There's not like a website they can
No,
go
there's
to
not, and we don't really make it public, but I know it's just something we use. If
Sure.
we come across an address that's, somebody, like a resident that's hoarding and it's, he has huge fire load in it, we'll put that if, this
Some
is.
of them have guns that
Yeah,
have been visible
yeah,
that aren't locked up, so
guns,
they'll
some
give us
of
an
them,
alert.
we go to the extent of like residents that have bed bugs,
I
that
have
kind of stuff.
two
we
questions.
we go all over the spectrum with what these alerts are used for.
So is it nice to have an alert that says there's a traced-vented child in the
I think
home?
that could be
Medically, a
legal.
medically
Yeah.
complex,
Yeah.
trach-vented child in the home? I mean,
I have
Well,
two
it just
questions.
gets you in the mindset. The
Mm-hmm.
more information we can have
Oh,
pre-arrival,
boy, do we agree with that.
yeah.
right?
A lot of times what happens is we'll get a shorter breath, but that's it.
That's it.
And then you walk in and it's a shorter breath trached patient that has a mucus plug. Just good to know. So then I'd bring in my section or start thinking of things versus just, I just know what I'm gonna do for a regular shorter breath, that's fine, but I don't see this very often, it would be good to know.
Because
Let
every
me ask-
second you can save is extremely
Right, and it
helpful.
also triggers us to go, okay, we're gonna again listen to what family is telling us.
Right,
Just
and look at all the
every
cues
little
on scene, yeah.
amount of time that we can save trying to figure out what the situation is.
So let me ask you another question with that. Would it be helpful to know, like, with our medically complex kids, that that's on the alert, but also that there is nursing in the home? Or anything like that? Is that going to be helpful to you guys or not really?
I think it would just be well, I can't say expected because there are some homes that don't have it.
Right.
And sometimes they have nursing
I
in
think
home, but they might have an open
probably,
shift.
The more the better, but then in a really compact way.
Yes.
So,
Yes.
in
Okay.
nursing home care for a trach pediatric
Muscular
patient.
dystrophy.
Not even age would be, it just pediatric
Yep.
Right,
patients.
because
So
it's
then
too
they
hard
just-
to maintain.
Right.
Yeah.
That was my
Right,
question.
that base, yes.
I know, we don't,
Yes.
it's not like we refresh them, not to my knowledge, on
Right.
a regular
Well,
basis.
my question is that just Minneapolis, Hennepin County, or is that metro-wide, this CAD? And would this material be, because I know Ramsey County dispatches there, Hennepin County
CAD
dispatches over there.
is our county-wide for North and Alliance. So when I say like West Metro or county, that means North, Alliance, and Hennepin. So we have the same, we have a medical director from each of those places, and they all come together to determine what our protocols and policies are going to be. They might slightly differ from one department from the other, like North carries vasopressin. Well, Hennepin doesn't, but it's in our protocols.
Sure.
Because we're all West Metro. East Metro is a whole different thing.
So,
That would be something, CAD, everybody should have CAD in our West Metro.
So
okay.
if we say Hennepin
So-
County, so for families in Hennepin County, is there a number they could contact to get their list on a CAD, or what were you thinking?
I'm sure we could talk to Wendy, and she would be willing to work.
Here's another question I have, and some of our families this might be an issue. Is this public record? Meaning, can anybody access with,
No, not CAD information.
Okay, because that's important, because I think some of our families would be willing to do that, but not if some nosy reporter or
We wouldn't even
civic,
need,
somebody
like,
comes
it
in
would-
and says, that's part of public
Well, it wouldn't
record, so I have
have to be
access to it,
specific,
but it
like,
might be
it wouldn't
private.
have to be name, age,
No.
birthday, just
No,
address
just
and complaint.
pediatric patient.
So it
and
wouldn't have
that's-
any HIPAA identifiers.
No, well,
No,
the
it wouldn't-
CAD information does, however, that is just between,
Right.
So it's
the
not public
crew and
record.
the-
Right,
it's
as
not
long
public.
as, and most of the time dispatch, and you could flag
So-
this not to have dispatch announce it, because if dispatch announces an alert, then people can hear that, people who have scanners and stuff can hear that. But a lot of times there's alerts on addresses that we don't want anybody else knowing about.
Right.
And then dispatch will just say, there's a note, please check your note in your CAD.
Right, because
Oh.
you don't want to say there's 20 shotguns in the home or whatever.
Yeah, exactly.
Gotcha.
Okay,
Yes.
so is that something that you can get us information on who we can contact?
We can
Because I don't
work
know
on
if that
it.
might
Let
be something
me,
we
you know, I'm
want
gonna
to.
talk to our communications chief, and I'll discuss it with her to see what the process is for getting alerts. And then if
Sure.
indeed we could add based on, you know, it would be your clientele and if they agree to put
Why
forth
don't-
the information to be alerted.
If the communication chief needs to talk to somebody on our end,
Okay,
I mean, it's a letter, I
Which-
mean, if we
which one
could
of
get
us?
approval for it, it's
Tamara?
probably just a brief letter we could draft up, and if you're interested,
sign
contact.
up, yeah.
Right, you know, put your information on the, well, actually, it doesn't, we don't need specific information.
We would just need address.
Right, address,
Mm-hmm.
and basic stuff. So if, maybe run this through you, you know, so when we get a number that we want to say, okay, we want our families to reach out, if they want information on this CAD, who can they call? You know, so if you can get us that information, and Tamara, if you'd be willing to receive that, and then we'll distribute it amongst ourselves. Come on over.
I don't want to be in the background of all these photos. I'm gonna wheel myself to the side of it.
Can you get through there?
You're just going to get yourself in a spot where
We
you
can
can make
hear
your
it
quick
makeup
exit.
too. Just-
Oh, you can get that on the way in?
No.
We had somebody
Clearly.
sitting right outside.
Okay. That makes sense.
I think
be
that
very
would be useful.
Because when we were planning this, we were always talking, you know, that was one of the topics that came up of, all right, when 911's called, what does 911 know
Nothing.
on their way over? And I
Other
think one of
than
you
what-
replied, say they might
Whatever
know
they get.
nothing and they
Yeah.
might
The
know
caller is telling
trach patient.
dispatch,
Exactly.
In a
What the,
panic, right.
right, and then.
I'm not coherent the couple times I've had to call 911.
Sometimes they can just say, these are the noises in the background. Sounds like,
Because if you don't have anybody talking,
Fisher
it's
Paykel
just-
heater.
and then you show up and it might be completely different than what you were anticipating
Right.
based on the notes, so.
Right. Yeah.
I would think that would be
Very
very
good.
helpful.
From a mom's perspective, I mean, that would be huge peace of mind.
Well, it would be nice to know that they've got some sort of an alert that they kind of know at least a little bit of what they're walking into.
but they
It doesn't have
also,
to be like super complex, but just the fact that there's a pediatric trach prevented patient
There may
that
be
has
short
a
rest.
history of autonomic storms. I mean,
Can
that mean
advanced
anything
records
to
be
you
noted
guys?
in
that?
That wouldn't mean anything to you
That
guys.
wouldn't mean anything, to our guys would
Okay.
read that and go,
No,
Yeah.
the only
Okay, so
thing
just-
is that, you know, like, you put short of breath, trach pediatric patient, or, please advise crews, we could put in there to take PPE precautions.
Oh,
So
that.
don't come in with
Audio.
dirty hands, you
Yeah.
know what I
Okay.
mean? We could
Okay.
try to do something like that, but
okay.
any of that other
That's not
would
gonna mean
not
nothing
be
to them,
useful for
okay.
them, no.
Would it be useful for them to know this is a wheelchair bound patient or not? Or that doesn't even matter?
Really, it wouldn't, because we would take them in the stretcher anyway.
Yeah, you would.
regardless.
It's just that you might find them in the wheelchair.
And they'll
or
walk
whatever,
up
but
and
that
see a
doesn't matter.
ramp,
They're gonna
you
see
know?
that anyways.
We're
They're
really
gonna
good
know.
at being like, oh, there's a
Yep,
ramp.
ramp, yep.
That is our note.
Yeah, yeah,
I
exactly.
just think knowing it's a pediatric patient with more complications than
Okay.
the average child
Okay.
is good to know.
Okay.
It just gets you in that
Mindset,
mindset of,
too.
okay, you know,
Then their brain can go back, oh yeah, I heard Erin doing that whole presentation. What did she say again?
right.
Yeah, I know, that's the hope, but.
well, why don't we, what we were planning on doing is showing you some of the stuff, you know, with the IV stuff, giving you some hands-on opportunity, take a quick break, I'll transition, and then we'll do some airway stuff, show you some airway things, trach stuff, and then the hands-on demonstration with that. We'll be recording some of it, so that, and then she's taking some still photos with it as well. And we already previewed a couple videos that we need to fix a little bit, and we identified one little fix, but that will be included as part of the things, and you guys can decide how you want to use it
If you
for
wanna use them, if you don't
taking
wanna
out to
use
your
No,
teams.
I already know we will.
Does that make sense? But we really appreciate you leaving this with us because we're going to do the same thing. We have a CPR mannequin that we're going to adapt into this guy.
And the video, Caitlin, the video that we take today, we could let them take back also if they wanted to use portions of the video training today for your crew too.
Definitely.
So
Yeah,
you
I can
could-
just send you like a YouTube link to
Yeah.
Oh, okay.
the whole thing and you can
When
just
is-
do whatever you want with that.
When is your first scheduled training after this?
October, the first Tuesday in October.
Okay, so we have almost a
6th.
month for that to be worked out. Okay, that's fine. That's cool.
And then what's the total number that you're training again?
Total?
Yeah.
Within the quarter. All of them or just each session?
Yeah, I'm just hypothetically, like, so October, November, December, right, are your three,
So it'd be like about 380 firefighters.
okay, that you're gonna be doing in the next quarter? Okay. All right.
From October to December.
Okay.
And how
But
many-
anywhere from 6 in a session to 45 in a session, or,
Yep.
I remember your number.
Six.
Right, so the first session will be great. It's Port Richfield, they're always our guinea pigs. But they are 6 to every Tuesday in October.
Okay.
So and and they have a lot of paramedics on their crews, so this will be a good kind of education for them, but then for us just to see what we can add or subtract, or because each department's a little different. So some of the more complex things will probably, maybe some of the vascular stuff we might just show, but then maybe for some of the paramedics we'll add the video of, because that was very good. For me, that helped me a lot, but it might not help a firefighter.
Amber, we'll be demonstrating with that stuff. That stuff unfortunately we won't be able to send with you, but we'll be demonstrating most of it on this.
Perfect.
But a lot of what she's going to talk about on here are in the
And I'll-
videos that we were
I can go
looking
here
at before.
and hear the same
I
thing.
do, if you don't mind, I might take a picture of your vascular ed picture. before
Yeah,
we leave,
absolutely.
just 'cause that's
Yeah.
a good reference.
And in the PowerPoint, she's going to talk about some slides, and she gave you the entire PowerPoint presentation, but there's a couple slides in the PowerPoint that have the routing of the catheters and stuff.
Okay.
And Jill will tell you, go to slide number whatever, and do it that way.
Sure.
That
And
makes
you can
sense.
just, kind of follow along.
Oh, I see.
I have just certain things in there, so, and I thought we'll just start, I kind of gave you a little infusion, but we'll just kind of talk about what we really want to drill home to everybody is that normal thing, and then we'll just kind of talk about if they came in and saw them seizing. I know you kind of have your protocols, but in a PEDS patient, what they might think about with our complex patients. Then I'll show some intro stuff, and then I'll go into the infusion stuff.
Okay.
How does that sound?
Yeah.
Does that sound good?
Sounds great.
Okay. Alrighty. Sounds good. So Caitlin, you tell me when you're rolling.
That camera's been on, so you can just.
It's been
Oh, it
rolling the
has.
whole time.
You got to edit that.
I didn't know when you were gonna start, I had to run on quick, so I just
Okay.
put it on.
So, as far as what's normal, and Bruce, you chime in again there
Yep.
too, but obviously, the biggest thing we want you guys to take home is just you're going to walk into many different situations of these complex patients. Their baselines are not textbook, hardly ever. So knowing what is their textbook baseline, or not their textbook baseline, but what is their baseline, and how are they deviating from that baseline is going to tell you a lot as emergency medical responders. So that's a question to ask the caregiver that would be in the home, or the nurse that might be in the home, or even the patient. They are alert and able to speak as, what's going on? How are you changing? How have you changed from what your baseline is? And that baseline might look very different than what you would learn normally in a textbook, like I said. So how are they looking different? How are they acting different? What are their vitals from their changes? From if they're a trach vented patient, how have they changed from their respiratory baseline? If they're an underlying cardiovascular kiddo, how have they changed from their cardiovascular baseline or a neurologic baseline? If they're a seizure kiddo, any of those changes. We just need to figure that out so you guys can respond appropriately to that. I don't know if you guys use a pediatric assessment triangle. I would assume you're very similar to that, but that's kind of what I go by when I teach my PEDS assessment classes, and just trying to figure out getting that information. assessing them. Is it, you know, a lot of our complex medical or our medical complex patients, there's a lot of them are nonverbal or neurologically impacted, or may have some cognitive impairments. So really, we're relying on how they're looking, and then what the caregiver or the nurse in the home is telling us. And so, what are their changes? Just looking at them, how is their tone changed? How about their interactiveness? Even if it's nonverbal communication, are they still able to, you know, blink, or are they still able to give us gestures or facial expressions, those type of things? Consolability for like infants, especially. You walk into a home and they're crying inconsolably. There's something obviously going on, and what is that? They can't tell us, but we have to figure out what it is from what everybody else is telling us, of course. So we're really going to assess their, you know, of course, their ABCs, their work of breathing, their circulation, so as far as work of breathing, we're just going to look at retracting, nasal flaring, respiratory effort and tone, abnormal sounds, circulation, how do they look, what's their skin color, are they pale, are they mottled, are they flushed?
Based on normal,
based
their
on-
normal.
Yep, based on what their normal would be. Yep, are they cyanotic at all? All of those things that we're looking at. And just doing the ABCs in general, which I know you guys do always as EMS. But I'd like to just stop and ask specific questions at this point, like when you're walking in at that point, what else is going to help you at that point? Just over with the whole scene.
I think first responders as a whole, they'll be able to hear
Okay.
an issue.
Okay.
We usually use our ears before anything else.
Okay.
So I can hear if somebody is filling up with fluid well before I get to that patient.
Okay.
So we're already thinking along those lines. If we walk into a home, let's say from a medically complex kid, we'll be able to hear stridor or hear something that will cue us in.
Okay.
So, and again, our eyes, you know,
Right.
we use, there's a wheelchair ramp. Okay, well, without knowing any information pre-arrival, okay, we're going to put that into effect. Extrication from the home is going to be a little bit different.
Right.
And then, again, just what do we see and hear?
Okay.
What we're told, the baseline would be one of the biggest things that we asked
Okay.
for. And I think in all first responders would be like, what are they like normally? And then go from there and see what happens.
One of the big differences is not all seizure appearances are seizure. Where we have kids who have dysreflexic episodes that look like a seizure, but it's not a seizure.
Sure.
So, you know, making sure the med's given, that's again, listening to the actual care provider there, because you had that experience where they were going to give seizure meds. It wasn't a seizure.
Or even the
So-
SATs. Remember, some of the
Right.
SATs are
Part-
different. So
yeah.
we're thinking, well, they don't look normal to us,
Right.
and their SATs are low. We would treat them differently. But then if the parent is saying, well, they're normally at this level because of this reason,
Right.
and believe me, they look okay, then we would take that and, you know, formulate our own treatment plan based on that information.
Right,
So
right.
that's really important for us to know, okay, they can't normally move, and then if they do move in a seizure activity, it looks like this, but it's not.
Right.
You know?
Right.
You
Yeah.
know, that's, unfortunately, we don't always have that help on scene to be able to, or maybe we're not accessing it to the best of our abilities, because if it looks like a seizure, we're gonna treat it like one.
And that's where it's super important. I guess that's the main message that we started talking about right away is, if possible, listen to the care provider, you know, and you probably will have to deviate from your textbook normal or your textbook responses based on what this kid's clinical history is.
And normally, other than probably cardiac arrest or something else that's extremely urgent, there is
Right.
always one provider that is talking to the caregiver or the parents, trying to get more information as the other crew members are giving care.
Sure.
So,
Okay.
You know
Excellent.
what would be kind of neat, honestly, is to do a video of a scenario of a role playing of having a crew come in and accessing the family and the resources, and then do another one where the patient's family is telling them and caregivers giving them the information they need, but they're ignoring them, and then based on that, the patient outcome might have been different. I know it's a lot of work right now thinking about it, but I'm just thinking that's how they learn too, is just look what's going on in the background on this, how much we're missing because we're not listening.
That might be something you could do with a live interaction though with your trainers. You know, you give somebody a
Yeah.
script, and then because I'm sure you identify your staff that, well, and we know our staff fairly well. We know which ones are going to do this and which ones are going to do that. You know, a response. So maybe
Ours
you
are
want
the
to
same.
set that up of this person who is Superman. You know, might be a very, very good responder or paramedic, but sometimes doesn't listen all the time.
I know. I don't think that's one thing we cannot stress enough with this training is for them to listen to the family.
But still respond.
But still
You know,
respond,
understanding
but-
that I don't have time for a dissertation here, you know.
Right.
But I, when we're saying don't give that seizure med, don't give that seizure med, you know.
And you know, another thing that's unique with the pediatric population, and you guys I'm sure have experienced this before too, but that just is making me think about that. But something that's real unique is that with peds population, they need that caregiver, whether it's mom or dad or whoever it is, right by their side for reassurance and for calming and for that. And so sometimes they kind of get pushed away, but that actually can aggravate the whole situation, and they need to have them there reassuring them. And with our nonverbal pediatric patients, I think one of the things that's important for the nonverbals too is they may very well be communicating with their caregiver or their nurse that's in the home, but your crew is not going to be able to understand anything that they're saying
Right,
to them.
because normally the kids, I mean, we pick up on that because the kids are like, Mom, you know, and, I mean, they're able to tell us that.
You know, because we've got some kids that all they can do is blink, and we've got other kids that will sign, and we've got other kids that just with their facial gestures or they'll nod yes and no, they're going to be able to communicate that. So that's just something to keep in mind too with your crew, is that that's an important piece, is that communication piece with especially our nonverbal or those that have difficulty communicating and you wouldn't understand what they're trying to communicate to you. Is keeping those families or caregivers close at hand.
In the interest of time,
Yep.
I'm just thinking, I wonder if we want to start getting into
Yep.
some of these parts and then
Yep.
moving along. I mean, what's wonderful, I'm sure we could spend 3 days
I
talking
know,
like this,
I know.
you know?
Okay.
But we also,
We gotta keep
I don't mean to be,
No, it's okay.
Every time
You
we
know-
get
Somebody
together,
needs
I
to keep
can't
us
wait.
I know.
I'm sorry, sometimes I've been told, and I'm too much like that,
Let's
but
keep going. Let's keep going. So I just put some normal ranges of vital signs in there, but remember your patients might deviate from that. As far as seizures, I know you guys already have your seizure protocols, but I think things that are important to remember in the home care setting for these complex patients is the ABCs, of course, but positioning them to avoid injury if at all possible. Confirming medication history, so what have they already been given prior to your arrival, and then what meds, and then also going within what is their seizure protocol and trying to, you know, because the family or the caregiver already kind of knows what works for that patient. And emergency medication administration is possible, and then consider IV placement, of course, probably all standard things that you guys think about. Enteral tubes, let's just talk about enteral tubes and the differences between them. So I have 3 different ones on this guy, but obviously you're not going to have all 3 of these at one time, but we've got them in just to kind of explain some of the different tubes that you guys might experience. So this is just a G tube, and it's just got a bolster attached to it. This would go directly into the stomach, so it would be considered a gastrostomy tube. This is just a little med port that you can put a syringe in to give medications through. And then this is typically the larger port where we would attach either a syringe, like just a regular 35 or 60 ml syringe that we could give bolus feeds through, and or we could hook up a feeding bag to that one. So that's just your gastrostomy tube going directly into the stomach. This would just be a Mickey button right here, and again, it's the same concept as gastrostomy tube. It's just a tube that goes directly into the stomach. On this one, when it's placed, it goes through the skin into a little stoma going into the stomach, and then there is actually a balloon and my balloon deflated. A balloon that you inflate to keep it in the stomach. So if you look at this guy, there's the balloon, and then that balloon is inflated, and that's what keeps it. Whoops, I just get this out. It secures it and keeps it in the stomach, so it just doesn't pop out. With this one, we can attach extensions. Oftentimes, you guys are going to come to the scene, And you may see that there's an extension already attached. A lot of our kids may already have a feeding pump attached or just the extension attached to it. And similar extension to this one, again, you can give meds through this one. And this would be where either a feeding bag is hooked up to and or a syringe would be hooked up to. And it just locks in. But that's not uncommon to see that. If this tube is out, if either of these would be out, sometimes they can be replaced. The family will have kits to replace them, and or you're just going to cover the stoma and go. So, those are those.
They also have a bolus.
Yeah, this is a bolus extension, which is nice to know about, because especially like if you were giving CPR or you came to a home and their stomach is extremely distended. If you use this bolus extension, you can attach it to the gastrostomy tube or the button here and just open it, and it will vent air out of their stomach. So something that's nice to know.
Man, I wish we had that when we were doing positive pressure ventilations, when everybody's belly was just
Right,
going
when
like
everybody's
this.
going, but on some of these kids, they can get
Yeah.
distended very, very quickly. So it's just something nice to know about that the family might have. And oftentimes they will have one of these in their e-bags with them. So if that was to happen, just something to kind of know about.
Now, if they did come out,
Yep,
what do you suggest for covering them?
just a gauze.
Just gauze pad.
Just a gauze pad. Doesn't have to be
Dry.
sterile, just a dry gauze pad.
Okay.
Yep. Just put a gauze over there. They're gonna go to the ER and have it replaced or wherever. So it's not, if either of these came out, it's not like a life-threatening emergency, obviously. If they came out, they would just need to be replaced. If the stomas that have been created are fresh stomas, like in the last month or so, and they're not well-established tracts, those tracts will tend to close more quickly than not. So, but typically they're going to have backup tubes in the home.
Some nursing homes that we go into, the nurse calls 911 for an immediate problem, and then this is kind of off track for just peds, but
Yeah.
that nurse is gone, and now we're with the patient, and they're in the middle of a feeding.
Okay.
Can you shut that off at any time? Does that cause any damage, or do you have to flush the line?
You
or-
can you could shut it off for certain patients. Now in peds patients, the thing that you need to think about is especially if it's a baby, a small baby, or it's somebody who has severe glucose fluctuations. Some of our peds patients are on a 24-hour drip. They're on a continuous drip, and that's because they need the nutrition and or they might have some glucose fluctuations. They might get hypoglycemic without it. In probably the majority of cases, you could probably temporarily shut that feeding off while you're en route to transport and be fine, and not worry about it for 30 minutes or 30 to 40 minutes. They're going to probably be just fine.
And you have to think about the reason why would you be called for something. It's probably more severe than just a G tube for those
Sure.
types of
Right.
patients.
So if
you're
Would
not,
it damage the tube if you're just clamping it off, unhooking it, if we don't flush or?
we usually flush with water, but you know what? In either of these cases,
And just
now
clamp
with the J tube down here, I'm going to tell you, yes, you should flush that one with water. These, if you've got time to flush them with water, great, flush them with water because it'll clear the formula through. It won't clog. If you don't, these can be replaced pretty easily. So this one is what we call a GJ. So you have two ports. You've got the gastric port and the port that goes into the jejunum. So if you look on your under enteral tubes, it shows you kind of where they go. But so the gastric portion, it's just like a G tube. That portion goes into the stomach. So you can give meds through it. You can flush through it. Typically, the kids that have a GJ tube are fed through the J. That's the portion of the tube that goes down into the jejunum, a little farther down in the intestine. And the reason they're fed through the J is because they usually don't tolerate feedings through the G tube into the stomach. They may end up vomiting those or whatever. So that's just something that's important to know. If you disconnect the feeding from a J tube, it is important to just flush it with a little bit of water first. 3 to 5 meals would be fine. Actually, what just enough to flush the tube. You don't want to put a whole lot into them. But J tubes tend to clog a lot easier than the G tubes do. So, and typically the J tube. Let's get this one gotten off. The J tube is on top and the G goes to the side. So this is not uncommon. This would be a very common, if you just ignore these two right here, it's not uncommon to see 2 extensions hooked up to a GJ tube. So if I ignore those two, so this is where my feeding would be hooked up to typically, and going into the jejunum. And it's not uncommon to walk into a home of a PEDS patient and see this, that you have a bolus and it's being vented into a diaper or something else. So they often will leave the G-tube portion that's in the stomach open because those kids may get distended very easily, and this is where they're venting the gas out of their stomach and into like a diaper, or they might have it into some sort of a bag or whatever. Not uncommon to
keep that clamp open.
see that. So this one's left open a lot, and they would be feeding through this one.
And the easy way for me to identify the GJ is it has all those extra little ports right there at the stomach. You know, where the other ones are
Yeah.
typically just a one thing.
It's got
You
2
said
ports.
the top goes the J and
This
the
is a
side
J,
goes
and
to the
it's stated right on there, like this one will say
okay.
jejunum, okay? And this one will say gastric. So it's right on there, yep. So now, with a G-tube, either a button or like one of these can often be replaced by the family. But with the J-tube, it has to be replaced in radiology, under interventional radiology, while they're placing it. So that's placed in interventional radiology. That's not something we're going to replace in the home ever.
So if it got yanked out, patch it and bring them in.
Yep. And a lot of our medically complex kids also might have some sort of a cathing protocol, so it's just something for you guys to know. They can't necessarily void spontaneously, especially those with any neurologic impact to their spinal cord. So this just is an example of a catheter that's going into the belly button, which is called a Mitrofanoff. And so patients are cathetered, they create a track in the belly button going down into the bladder, and they're cathetered right through the belly button. Some of those patients that have a Mitrofanoff have been closed up from down below if they're female. They don't have any, they can't access the urethra. Some still you can access the urethra. So it's just something to know that if
that
they needed
just
to be
for-
catheterized.
Prevention of infection more than anything?
It's
The
more,
direct-
no, it's the creation of the Mitrofanoff tract is really more for creating independence. So, think about if you're wheelchair bound and trying to cath from below, it's very difficult. You can just cath right into the belly button and be done and on your way. So it's a lot of ease for them. And it
Does your
creates
staff ever
independence for
do
them.
urinary catheters out in the field?
Nope.
Nope.
I wouldn't
So
expect
what
it
if you
back
have a
this
really
summer.
over-distended bladder? You don't cath or anything like that?
We do not.
You do not?
Nope.
Okay.
The only this gal I can think of that we routinely get called to is on Washington and Hennepin, University, whatever. It doesn't matter. But she's in a wheelchair, and her cath, she has trouble reaching it,
Okay.
and so
Yeah.
that's why we usually go is to
Mhm.
empty her bag, and then she has some cellulite problems on her, or edema problems on her. What am I trying to say? The pitting edema, cellulitis
Mm-hmm.
on her legs that chafes, and she has problems with that. So then
Okay.
we go and put cream on it,
Right.
So I can understand now why that would be
Okay.
important.
The only thing that would be important with some of our pediatric patients that have spinal cord involvement would be that they have neurogenic bladders, and if they get an overdistended bladder, that can lead to an autonomic dysreflexia that can be potentially life-threatening for them, and that could be something that you could potentially be called to the home for. They get severe hypertension, they can sweat profusely, they can get hypothermic. So those are some things, and one of the ways you correct that is just by getting them catheterized or getting their bladder emptied somehow. So it's just something but their caregiver could
Yeah.
totally be responsible for that. So, and then we have all kinds of different ostomies that you guys might come across. Colostomies, ileostomies. I mean, there's just a whole lot of different types of ostomies that you might come across with that they may have an ostomy pouch on. Really, there's not going to be anything urgent for you. The biggest thing that I would see for you guys in the field, and you can let me know if that's different, but you get a call, the bag has come off, they're leaking all over or whatever. What do you do with that? If they don't have extra pouches or whatever, you cover and you go. I mean, cover with just gauze again and transport. So that kind of covers kind of tubes that way, and then I'm going to get into infusion. But do you have any other questions about like feeding tubes, that type of thing, that would be helpful for your staff?
Oh, that was very helpful.
Right.
Okay. So Obviously, just they wouldn't have all three.
Right.
So just so that but we just put them
Oh my
in
gosh,
so
I
it
can
kind of.
see going.
They're gonna look at that mannequin and they're
Just,
gonna go.
you gotta show them one at a time.
We're gonna cover with a sheet before they walk in.
They'll be nervous with one
These two are the same thing. They're gastrostomy tube. They're just different types. The thing about this is you go from this to usually this to get a low profile button, so you don't have to have this big thing hanging off of you. However, a lot of adult populations are still going to have this type of a deal on them. But your peds patients, the majority of them, you're going to see this or like a GJ. So.
Keep in mind, though, they may have two. If one's in the G, in the gastrostomy
They might,
stomach,
yes.
and one's in the J junum. So just
Yes.
not to throw them off, just
Right.
based on whatever's going on with them, they may have two.
Yeah, they may not have it as one
And the bladder
here.
access.
They might have like two buttons, one in the stomach, one in the jejunum. Yeah, good point. Good point. Okay, so let's just get into some infusion overview and ask questions as we go. I'm just going to go on your.
We can take the vent circuit off.
Nope, it's okay. It can stay right here. On this guy, because you're going to be using him a lot, let's just go over the different types. You guys all know what peripherals are. You guys place them in the field, so I'm not going to go into that. The only thing I would say about peripherals is that there are certain medications that aren't always given into peripherals. And not that you guys are going to know all of those, but it's those with pH less than 5, greater than 9, osmolarity greater than 600, or a continuous vesicant like a chemotherapy, that type of thing. Those with an osmolarity greater than 600 are like your parenteral nutrition. We don't typically give that into a peripheral line. So he's got a PICC line right here, just like my arm over here has got a PICC line here. A PICC is a peripherally inserted central catheter. So these are all central catheters that I'm going to talk about now at this point. I just want to just kind of clarify. So a PICC, it's inserted usually into the cephalic or the basilic veins. It would then be threaded, the catheter would be threaded up through the subclavian, and then the tip sits right down here in the distal portion of the superior vena cava. All central catheters, the tip ends right here in the distal portion of the superior vena cava pretty much. So where it inserts through the skin, it also inserts right into the vasculature. The kiddos that you guys are going to see with PICCs out there are going to be the kiddos that need short-term, like several weeks to several months of, might be long-term antibiotic therapy, like maybe a couple months for an osteomyelitis, something like that. It might be a kiddo who's getting parental nutrition through his PICC line for short-term, like maybe a month or two for bowel rest, something like that. So those are the kids that you're going to see with the PICC lines. Our tunnel catheters, like he's got in the chest right here, and Chester Chest has one right down here. Let's get this one out of the way for now. He's got one right here. Is a tunnel catheter, again, usually is in the right or the left chest. The catheter is placed, it's tunneled underneath, then the catheter accesses the subclavian and then ends up down the distal portion of the superior vena cava. With a tunnel catheter, the nice thing about a tunnel catheter is that there's a cuff that goes right inside the insertion site usually, and that cuff, the tissue grows into that, but that cuff also prevents bacteria that might enter into the insertion site from traveling up the tract and into the bloodstream. So a little bit less risk of infection than a PICC would be.
With a tunnel catheter, will they see a bump on the skin?
You might see a bump.
Because
Yes,
it's
you might
just
see a
right
little bit
under
of a
the,
bump.
it's right under the skin.
If you see the catheter, if the catheter gets dislodged and you see this cuff that's attached to the catheter, that means that definitely that catheter has been dislodged partly. If there's a cuff on the outside, the cuff should always be on the inside of the skin. Okay. The kids that would have a tunnel catheter are going to be our hemoc oncology patients, our transplant patients, or our long-term TPN parental nutrition patients that are getting nutrition through their veins. A tunnel catheter can last a year to 2 years, and again, less risk of infection for a tunnel than it is for a PICC. We have our port. So Chester Chest has a port that's accessed here. He's got a port that's right here. So I can palpate it right here, but it's not accessed. So when a port's not accessed, there's nothing on the outside of the chest wall. A port is a catheter that is attached to a reservoir. So they create a port pocket surgically. The port is sutured into that pocket. Then your skin would be covering that port. And then it's accessed with a special angle needle called, called either a grip or a safe step. There's just different types of needles. There's more than that out there, but here's one example of a needle. It's a special angle needle, So that, because the port can be accessed up to 2,000 times, left in for 5 to 10 years. So this angle on the needle prevents coring out of that silicone septum in it. So I would feel it, and I would go dead center in that port, and then I would put a dressing over that. When you go in there, this is what the port body looks like. The port itself is made out of plastic, stainless steel, or titanium. This is a self-sealing silicone septum, and then the reservoir. So where that needle ends up going through is you want to go dead center through the port, right through that septum, and then that needle sits right down in the reservoir. And then the catheter comes off the side and goes into the vessel. Okay?
So would that be placed when you don't need to access it very often?
No.
Or what's the
A
reason
port is
for-
used for, most of our kids that get ports are kids that have poor peripheral access that need frequent long-term intermittent therapy. So when they don't need anything, there's nothing there. There's no risk of infection because you don't have all these lines hanging out. So a lot of our kids that get the ports are maybe kids that are on and off of IV antibiotics frequently and they don't have much periphery to do. They might get an enzyme replacement therapy or a medication called IVIG that's given anywhere from 1 to 4 weeks apart. And so they're having frequent access, but they don't need a peripheral stick and multiple sticks that in a vessel that's not going to support that medication. So, yep, you sure can. And if you guys
Would-
want to take pictures up
Be
close,
careful of the needle.
okay, sure. And there's one other, that's the kind of a port that would be, usually the ports are placed in the left or the right upper chest. You might see them right between the nipple line, and then in a lot of our peds patients, we're seeing them over here on the side.
And
Okay,
some
so
right
you
in
might
lower?
see them here, 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 or up here.
Did you say?
On a rare occasion, you might see them in the upper abdomen, but that's pretty rare. You don't see them there very often. And then there is one other type of a port. It's a much smaller port than that one. This is called a passport, and a passport is in the arm. So, and it'll be right on the inside of the arm. So most of the patients that get passports are our adult patients that want to be independent and access their own port. So most of our peds patients, you're not going to see a passport, but there might be one in adult patients.
Would your staff ever be directed to access, okay, instead of trying to start a peripheral IV, they say they have a port, would your staff be able to?
The paramedics, yes, they don't have these needles though.
But the families,
families
would-
would.
They'd be able to use,
Yeah.
yep,
So the
So-
family might access the port and you guys would add the meds?
yes.
Yep, that would be a situation too, or the nurse in the home would, yep. If you have paramedics that are trained in port access and they need to get that patient accessed for some reason, there's not somebody that's trained except for your paramedics, know that in their emergency kits or at home, they're always going to have port needles, dressing kits, everything you need, saline, heparin, everything you need to access that port. It's going to be right there. So, yep.
It's a lot easier than
I know,
Yeah.
I've never seen
Uh,
this type.
Honestly, accessing a port is easier than starting a peripheral IV.
Yeah.
It's one quick poke.
She did
Boom,
one,
boom.
one of the
Right.
videos
Yeah.
is her doing it
Yeah,
live on her
it's
child.
just, yeah. The one thing about a port, you do want to get it dead center because if you don't, you could hit the side of the port. Then you're not going to be able to get down into that reservoir. You're not going to get blood return. You're not going to be able to infuse. If you got it on the outside of the port, one of the complications that could happen is that you could hit a vessel. So you want to make sure that you can get in the middle of that port. You always want to have a positive blood return with a port before using that port to administer any medications. If you don't get a positive blood return, you should not be using that port. So just something to
Then
think
they
about.
just feed this through with a wire or how do
Yeah,
they?
it's all wire guided.
Yeah.
Yep, when they do that. Yep. So typically when they place a port, they'll make a surgical incision and then they make an incision up here that they help guide everything through. They place that port and then they all thread it up into where it needs to go. So
How much are they, the volume of whatever fluid you're putting in, is there a limit as to how much you can put in there? So if you had a kid who was hypotensive and you wanted to add some IV fluid,
no,
You can do
it's
that.
just like it's like
Just
a
like a
peripheral.
peripheral.
You can you
So
can
it's
give
exactly-
a
okay, all
you
right.
can give a bolus. You can give a bolus of fluid. You can give meds through a port. All of these lines that I'm showing you, you can give meds through them and you can give fluids through them. So
if you do it through a peripheral, you can do it through a port? Mm-hmm. Okay, that's important to know.
So, yep. And then Chester Chest just has an example of a percutaneous inserted non-tunnel catheter up here, up into the IJ. Those are usually placed in the IJs, the subclavian. So they're usually placed up in the IJ, the subclavian, or down in the femoral, and down by the groin. And those are usually really quick access. Like those are the ones you guys are going to see. They're placing in the ERs, in the PICUs, the ICUs quickly for quick access. Do you guys place them?
We do EJs.
EJs, okay.
Yep.
So, yep, but they're usually short term. They're almost always sutured into place. They're usually 5 to 10 days, but in the peds population, I will tell you, they might have had some of these other lines previously. They've lost access because of complications for whatever reasons, and the only line that they have left right now might be like their IJ, their subclavian, or maybe their femoral. So you might see those out in the home care setting, and you can use them just like any of the other lines to administer medications and or fluids through. So, with all of our lines, we should always have a needleless valve at the end of the line. So you'll see that this little valve is just, everything is needleless. If this is off, you've got direct access into the bloodstream. So bacteria, debris, whatever could have gotten in there. So you should always make sure that those are on at the end of your lines. This is a double lumen catheter. So with this one, there are actually 2 lumens coming off the catheter, and I'll just show you.
I'll find it.
What did I do with it? Oh. No,
Uh,
but what did I
page
do with
11
my
at the
line?
bottom.
Yeah.
Page 11 at the bottom.
But I had a sample over here. Here it is, right here. Just want to quick show you this one. So,
Oh, I see. Yep.
so with a double lumen, there's 2 lumens coming off. So there are actually, it's only one catheter, but there's 2 separate lumens inside of there. I'm going to show this to you. So there's a split septum. So you can give non-compatible medications. They're not going to mix in here because there's 2 separate septums inside this catheter. With a triple, there would be 1 more coming off. Okay, there'd be 1 more, and I'm just like this one right here.
And
So
that
there
one-
would be 3 coming off like that. So there would be actually 3 septums inside of them. The red is always going to be the larger septum. That's what you give blood products through or draw labs off of. And then you would have the 2 smaller septums in a triple. So just for you guys, like if you were in the field and you went and you found a triple lumen and you needed to give fluids quickly, always go for the red lumen because it's going to be the larger of your lumens typically. It's going to be the larger of your lumens.
That's interesting. You have brown, cream, and blue.
So, and then one thing you just don't want to be fooled on is this is a single lumen with just a Y extension on it here. So sometimes we run
Which is on page
compatible
12.
medications.
Top of the next one.
So when we run compatible medications, we might need 2 ports to run them through, but they're only going into 1 catheter. If I took this off and just had, one of my needleless valves on the end of it, you would see that it's a single. It's just a single catheter. So you don't want to get fooled by just like a Y extension on the end of it.
So let's
Does that make
compare.
sense?
Yeah, because
Compare that.
I always thought if it had additional access points to it, it just meant for different medications or fluid, or if I want to give something at the same time, like adenosine, you have to give that and then give a saline bolus
Right.
immediately, so
Right.
then I can load up my adenosine and load up my
You could
saline
do that
and
with
it at
them
the
because
same
they're
time.
compatible. But now if you were going to give, if you needed to give incompatible medications at the same time and you
Right.
gave them through here, they're going to mix. So you don't want to do that.
So you see the Y is what is
So,
indicative of
yep.
what the actual lumens are
Right, you want
inside.
to look at where the catheter starts. Look at, this is only 1 lumen. If you look at this, you can see 2 lumens coming right off of it.
Alright.
Yeah, so that's just one thing that you want to just be aware of. So, you also might see these little green caps on the end of these lines. These can be taken off and chucked, no big deal. What they are is they're just called the little Kuros cap. There's a sponge on the inside with alcohol. All they're doing is keeping the end of that line clean. So if you need to access your line, don't worry about these little things. And sometimes they're blue, sometimes they're white, sometimes they're orange. So just take that off. You're still going to have the needle stuff. All it's doing is covering the tip where you're going to access with your saline and your meds through the line. Okay. And then when we think about using our lines, we always think about the acronym SASH. So we're going to, if you think about S would be saline, A is administering medication, S is saline, and H is heparin. Heparin, you're only going to use if you're not going to be using that line for hours, just to keep it from clotting off. But in the emergency field for you guys, you're going to be, flushing with saline, giving a med, flushing with saline. If you have to give another med, flush again. But you should always be flushing with saline in between meds to clear the meds so that they don't, if they're non-compatible, they don't mix with one another. That's the acronym STASH. Another thing that you guys might see set up in the home care setting is you might walk in and they have a PICC line like this, and there's something like this set up. This is just an Eclipse. This is a common way we administer antibiotics, antifungals, antimicrobials at home. And so you might walk in the house and they've got this running. Well, all they're doing is administering an antibiotic. If you've got to give emergency meds or emergency fluid, something like that, you can just shut it off and just disconnect it and start using their line.
And it's not gravity dependent, so it doesn't
No.
be higher, it can
No.
be,
Yeah, it doesn't mean.
It acts like a balloon with pressure. As the medicine instills, it deflates. So you might see that. Another thing that you might see is you might walk into a patient's home and you might see a kiddo set up with like this baby. She's got actually two different things going right now.
Ivy.
So this is baby Ivy, but you might walk in and you might see, this is very common, even with a baby, this is what you might see, okay? Where she's got a backpack and she's got something infusing into her. This is a common way that we administer TPN. We put all of the pump and the medication and everything right in this backpack. So even with babies, we do so parents can just pick up the backpack and carry it. But here's our infusion pump right here. Here's our TPN, or our parental nutrition, and it's running via the pump right on into her. So again, if you needed to stop it for some reason for emergency medication administration, you just stop the pump and, or have one of the caregivers who's ever with her stop the pump. You would just disconnect it and be able to access her line. Whoops, sorry, I disconnected. That's not what you want to do. Just disconnect it here, and then you can access it with medication. And so that's one other thing that you might see. You commonly see our infusion kiddos with backpacks with their pumps and their fluids right in there. Here's just another example of a bag of fluids and another type of pump that you might see infusing into a patient at home. So, as far as the infusions, what's infusing into them, it is important to maybe ask the caregiver or the nurse that's in the home, is this something that can be disconnected for them without causing hypoglycemia? But some of our real small babies that are on parental nutrition, if you stop their parental nutrition, it could cause hypoglycemia in them. So it's just something to think about with them. So, I think. And then I was just going to talk about some quick complications that you guys could potentially be called for at the home for infusion-related complications. A big one is just an occluded catheter. So I don't know if you get a 911 call for that necessarily, but you could potentially.
page 14.
Just they can't flush a catheter. One thing you just want to know is, and all your EMS personnel, is you never flush a catheter forcefully, because there could be a clot, some sort of a clot sitting in there, and then you'd cause an emboli, which then you'd have complications. So if you can't flush, one thing that you could try doing is you could try drawing back just to see if you get a blood return, and then waste that off if there was a clot sitting in there, if you really needed to access that line, but never force a flush. Typically the one thing people forget to do is they forget to unclamp the clamp. So that's just something to think about doing, is checking your clamps.
Yep, that happens
But
a lot.
never force a flush. You, never force a flush that would move a potential occlusion like a clot in there. And there's several different types of occlusions. There's 4 different types of thrombus occlusions, blood clots. There's precipitate occlusion that can occur from medication. And then there's just mechanical occlusions also. Sometimes our central lines, they can get pinched between the clavicle and the first rib. And if there's an occlusion, one thing to just try to have them do, is if they can, or if a caregiver can, is have them move their arm up or out, or reposition, and it can move that mechanical kink that might be there. So, and remove that kink. You might get called for vessel thrombosis, vena cava syndrome. superior vena cava syndrome, that can be a potentially life-threatening complication. That's something that you might get called for. And we're on page 19 now. What happens is the superior vena cava, so that big superior vena cava gets occluded by some sort of a thrombus. Okay? And then it causes interstitial edema, it causes retrograde collateral blood flow. What ends up happening is they will get extreme swelling in their neck, maybe up in their shoulders, up in their face. They can turn kind of a bluish black color. They can have respiratory distress, and it can be potentially life-threatening. They've got to get to the hospital. They've got to usually be put on anticoagulants. They're going to need your support, probably just with oxygen and seeing if you can get another line started, but usually they end up having to pull that line, but it can be a potentially life-threatening complication. So I'm kind of just touching on the ones that I think that you guys might be called at the home for most often, and that would be one that you could potentially be called for.
I can see that.
Superior vena cava syndrome.
That would just start constricting their airway.
So what would they do? I mean, what would their staff do?
ABCs supporting them, maybe get another line going somewhere there. You can support them that way, but really it would be supporting them from a respiratory standpoint and getting them to the hospital as soon as possible. Darkening of the skin is another thing that can happen with that too. And then the other thing that you see is if you see really distended veins like in their chest area, that's usually an indication that they're starting some superior vena cava syndrome. So just something to think about. Catheter displacement, catheter gets pulled out and they're bleeding. Like if one of these lines got pulled out and they're bleeding, direct pressure on that line, on that site for at least 5 minutes. And then they would just need to get that line replaced. Depending upon what that line was being used for, typically that's not necessarily a life-threatening emergency, unless they are on a drip, something like a milrinone drip, and that could be something that you guys could be called for. We have several kids out there that are on life-sustaining drips. Milrinone is one for heart failure, so they on that drip both pre and post heart transplant. And if they're on that type of a drip, they have very specific protocols that they need to be to a hospital within this amount of time, because without it, their heart can stop because it's supporting their heart. So that's something to think about. And in that situation, what you guys could be called for is, hey, their line is occluded, their line got pulled out, they're on this life-sustaining drip, like a milrinone drip. The big thing would be to get some sort of line started and get that drip restarted for them. So even if it's just a peripheral line, and get that going for them.
Those kids are usually pretty close to the hospital too, aren't they? Like the Ronald McDonald area there about the
Yes, a lot of them are, but we have sent patients home to Greater Minnesota and Greater Wisconsin on milrinone drips. And so we have a real specific emergency action plan. So that's always one thing to just always ask when you walk into the home. Do you have a specific emergency action plan? Like with those kids, they have a very specific plan. If they're away from the metro hospitals, like the U, that's where they would come out of for pre and post heart transplant. But if they live in Greater Minnesota, or if they live in the North Metro or wherever, depending upon how long they can be off those drips would depend upon where they would need to go. If they can only be off for 30 minutes, it might not be, they might need to go to North or Mercy or someplace just to get another line started to get that drip going, Most of the time they have 30 to 60 minutes. So if they're in the metro area, you'd be able to transport them back to the U. So it's just something to think about. Phlebitis is just an inflammation of the vein. You can get redness and pain, warmth, swelling, swelling of the upper arm, the shoulder, the neck, streak formation, palpable venous cord. The big thing if they start showing signs of phlebitis is you don't use that line. Usually it has to get pulled at that point. Infiltration and extravasation, that's something that you guys might see out there, especially if patients are out on, they've got peripheral lines in, but even if they don't have peripheral lines, you can get infiltration and or extravasation through a port also. So infiltration is the accumulation of non-vesicant fluids in the tissue. Extravasation would be vesicant type of fluids in the tissue, which can cause severe necrosis and that kind of thing, so like a chemotherapy. If you got a kiddo with a port, and a lot of our families give some of the chemotherapy at home, you got a kiddo with a port, and that needle comes out of the port septum but stays in the tissue of the port, or of the patient stays in the tissue, but it's out of that septum, then what happens is that fluid is now going into the tissue, and that's where you get either infiltration or extravasation depending upon what you're infusing. So the big thing is if you had some sort of a vesicant type therapy that we're doing, you got called to the home saying, hey, their chest is all swollen, I had a port in, I was giving chemo, and now I noticed it's probably leaking into the tissue, is you pull off as much of that fluid off as possible through that port. Leave the port intact, pull it off, and then you would just transport them and let them know en route. Sometimes by the time they get there, they can talk to pharmacy and the physicians there, and they can give something to neutralize that, whatever extravasated into that tissue. So, one thing to note is with extravasation, you guys could potentially get called days to even weeks post-infusion. Sometimes if it extravasates into the tissue, it doesn't actually start causing tissue necrosis and things like that until a few days to a few weeks out. So into the tissue. So it's just something to think about. And then one of the biggest things that you might see is an allergic reaction. And you guys, I don't know how often you get called for that, but you could potentially, for any of our kiddos, we have a lot of kiddos who are getting infusions that have high risks of allergic reaction. So, and with that, obviously responding with them, depending upon how severe a reaction. Most of our kids that have the potential for reactions, we make sure that we have Benadryl in the home, EpiPens, and that kind of thing. But it would be just to go ahead and figure out whether or not they've already been treated with an EpiPen or Benadryl, and then to respond appropriately like we would normally. So, and then air embolism is another one that you guys might get called for. I think I'm going ahead of myself, but air embolism. So if they had an air embolism, most of our peds patients, it would be unusual to have an air embolism because we prime everything out of our tubing, our saline syringes, all of that. But with an air embolism, if they started showing signs and symptoms of that, the best thing to do for that is to get them in a left lateral decubitus position. So you get them on their left side with their head down as much as possible to prevent that embolism from going. And then you would support them again from a respiratory status and cardiovascular status, depending upon how they were presenting with that. But that again can be a potentially life-threatening. If you have a damaged catheter, and that might be something that you could potentially be called for. They've got maybe this triple lumen right here, and one of them, somebody accidentally cut one of them off, and we've got blood coming out of it. So the big thing is just to get it clamped off. So easy way to instruct them or to do it when you get to the home is if it was cut, if this one was cut all the way off here, just clamp it, put a piece of tape around it, and you got it clamped. All of our patients also have emergency kits in them, and there is where's my Kelly clamp? It's not in here. I think it's over in my bucket. But we also have Kelly clamps. Let me just grab that really quick, and we would just clamp.
I guess you guys have forceps Kelly clamps.
I always teach what's practical because sometimes you don't have these Kelly clamps, but you can just clamp the line, and then they would just need to transport and get that line replaced. So that's another one that might occur with them.
I have extras of those. So.
Yeah, we got lots of those. So, and I'm just going to see, and then pulmonary edema. Obviously, you guys have dealt with that plenty of times, but our kiddos can. The thing about our kiddos is that they can get into circulatory overload and pulmonary edema pretty quickly sometimes, especially if they have underlying cardiovascular disease, and those are our kiddos who get into it most commonly, are those kids that have underlying cardiovascular disease that might also be getting some IV infusions on top of it, and they can get into respiratory distress pretty quickly. So a lot of those kiddos are also on Lasix and other antidiuretics. So
well, I see that you said it was slow infusion, not necessarily stop it if they are suffering from little CHF.
Right, you might just slow it down, but you might have to stop. I mean, it's going to be your judgment call when you're there, I mean, remember, I think most of the time, by the time you guys arrive on scene and get to the hospital, it's 30 to 60 minutes or less, or sometimes less than that, So, I mean, most of all the infusions I've showed you, except for something like Milrinone, that's life-saving, infusion, most of our infusions could be shut off temporarily if you needed to. And it's not gonna cause
Well, and
a
if
lot
they
of
have
harm to
the-
the patient.
The transplant medicine, I mean, obviously there's gonna be people there that know.
Yes,
you
yes.
know,
And they
not to
should be
shut it
also
off.
wearing a medical alert bracelet, although I will tell you a lot of them don't. But if it's something that's, you know, life sustaining like Milrinone, somebody should be with them that knows that. So, yeah. And then another big one that can happen is speed shock. So speed shock can happen from a medication being administered too quickly. The organs aren't able to metabolize it quickly enough, and you get speed shock. Have you guys ever dealt with speed shock
I've
at all?
never heard of it.
I
So
would think that would be very probable when they work on this.
Cause all of our medications, we have to give. right?
they have to give push, so I mean, it's not,
Right,
but, you know,
right.
but some medications that can cause speed shock are things that might be given in the home care setting, and maybe they're given and that patient, you know, has underlying conditions that we don't even know about. Because you remember, a lot of our patients are complex, but that has caused their organs not to metabolize that medication, and that can create speed shock. A push medicine that was given too quickly can cause speed shock. So signs and symptoms would be facial flushing, headache, chest tightness, irregular pulse, hypotension, loss of consciousness, all the way up to cardiac arrest. So it is something that you could potentially see. I've only seen it once in my nursing career with a peds patient. But what classic signs for it when it starts is they get very rapid onset of a headache and severe facial flushing. And so the biggest thing is just to stop what you're administering it for a minute, and or slow it down, or just wait for a little bit. But you could be called for potential speed shock, which can cause cardiac arrest. So you could potentially be called to a home with cardiac arrest. So just asking, has any medications been given recently, anything like that, might help you know what could have potentially caused that arrest. So, and it could be speed shock. So
And if.
it's very
If
rare.
you stop it, if you see those symptoms, how long does it take for those symptoms to?
It depends. It depends upon how long it takes the organs to metabolize the
much
medication
they
that's
got.
being administered, how much they got. But the biggest thing is if you start seeing it and they start complaining of those things and you start seeing some of those symptoms, is just to stop administering what you're giving if you can, to prevent speed
So
shock
you've been a
from
nurse for
occurring.
30 years and you've seen this how many times?
I've seen it once.
Okay.
So it doesn't happen all that often, but it does happen.
You never
If
know.
they do,
You
they're gonna
never
call
know.
you. But no, if they
And I
do,
know
if
that
they
a
do,
lot of these
they're gonna
things-
call you.
Anything could happen.
Okay.
I know.
I
I know.
It helps put it in perspective, but no, it's,
Right.
I'm going,
And-
oh boy, what
Yes,
happened?
yes.
Well, and I always wonder how many problems there are with pumps that affect the delivery of the medicines.
There can
and
always
how
be
that
problems with
can-
pumps.
Yeah.
But we, in the pediatric world, we don't do any gravity drips in the pediatric world at home at all. Not through us anyways. There's too high of a risk of fluid boluses, medication administered way too quickly. It's always via like an Eclipse or one of our infusion pumps. Nothing is given at all.
Feeding.
Not
They'll do
Well,
feeding.
yeah, but feeding is
via
not
gravity bag.
IV.
No, I just want to make
Yes,
sure that
yes,
people understand
that is true.
They
Yeah.
might see a bag dripping, but that's
Yep.
feeding.
Right.
It's-
But not an
Not a
IV.
medication.
You'll never see an IV gravity drip in the pediatric world in the home care. I mean, that would be extremely rare to see that. That reminds me, so on something else that you could potentially get called for is we have had either oral or enteral medications drawn up and given via IV. So, which they're not sterile usually. There can be precipitate in there that could cause some of these complications I just talked about very rapidly. That could cause that patient to crash very quickly. In some situations, it could cause death very quickly. So that could be something that you could be called to for, you know. Very rare, that doesn't happen very often, but we just had it happen this last week with a patient where, you know, an exhausted caregiver who's meticulous ended up, you know, drawing up something that was supposed to be given through the tube and put it in the IV. So it can happen, but good outcome, thankfully. So, and then one of the last complications that can occur is that you very, very well could be called for would be a child that is developed a very rapid onset of a fever, and they have what we call a central line related bloodstream infection, where they've got a central line bacteria's entered that line, it's gotten into their bloodstream, and now that they've got, central line-related bloodstream infection, that can lead to sepsis and death very rapidly. And I've seen those patients go from a temperature onset of 99 degrees to 107 degrees in 30 minutes and in a full code situation. I've also seen where it's been a more gradual onset, where they have a fever, the next day there's a higher fever, and then a higher fever, and then they've gone septic. But that's not an uncommon complication at all, and you very well could be called for that in the home care setting. Those patients, they will get very cyanotic. Usually they'll get real mottled, kind of a pasty gray color. You guys see many septic patients at all? Mm-hmm. Yeah, kind of that gray, very hypotensive. I mean, it's going to be to come in and support them and get them emergent care. You're probably going to be given fluids to support their hypotension and that type of thing. So whatever your protocols are, but not uncommon at all to be called out for something
What
like
does
that.
CLABSI mean?
Central line related bloodstream infection. So really what happens is just systemically in their bloodstream, they get a lot of bacteria,
Okay.
and that can lead to sepsis. And it's not uncommon when you have sepsis to also have DIC associated with it, with just disseminated intravascular coagulation, where all your clotting factors go out of whack and they start bleeding also. So those patients become critically ill very, very quickly. And with the central line, it's a huge risk. So that is another complication that you might be called for.
So the good news about the central line gives us a nice line that don't have to worry about peripheral. The bad news is really high rate of infection.
But the good news is if you do everything that you do, meticulous site care, meticulous care scrubbing the hubs, making sure you keep everything sterile, that's got to be sterile. Our CLABSI rate is like 0.21, 0.24, which is phenomenal for our patients out there. So considering that we're doing all of this stuff and teaching our families to do it in the home care setting.
Yeah, I mean, a mistake could be fatal.
Yep, a mistake could be fatal. It could be very fatal. So what kind of other questions infusion related? Does that help explain? Does it help show?
Yes.
Yes?
Absolutely.
Yes? Okay.
Yeah, and like I said, I mean, the information that you're giving us is what we need to know, and then we can kind of curb some of that for them.
Okay.
To be able to understand, but it absolutely, I mean, a lot of it's
Okay.
made sense, but not a lot of us have a lot of training
Mm-hmm.
and knowledge in that, so definitely infection control is huge.
Yes, it is.
And then accessing that port is a huge one too, anything that's,
Mhm.
it's
And-
good to know why they're accessed and where they're accessed, but also the parameters in which we can, and that, hey,
Right.
you can give anything peripherally, you can give it port, that's good
Right,
to know.
yeah.
You know?
Actually, you can give more medications via any of the central lines, which are all of these that I just showed you, than you can peripherally.
Mhm.
So there is one catheter I didn't talk about that we should quick talk about. Patients that have hemodialysis catheters. Usually hemodialysis catheters are off limits to everybody except the hemodialysis team. So it's just something to know.
Where are they located?
They're very similar. They can be in the arm, some are in the chest. I mean, most of the time they're in the arm, but you can have a hemodialysis catheter in the arm, in the chest also. So it's important to ask, if you see lines, are any of these hemodialysis lines? And if they are, those are usually off limits. They're even off limits to us going out typically and doing anything with them. I mean, the only people that touch them are the hemodialysis staff.
Is there anything specific to that line that's gonna?
They're very similar to this. They're
Yeah,
larger.
that is-
They're larger bore, so you have a much higher risk of an air embolism in those. So you've got to make sure that they're clamped.
I'm just saying,
prior
as
to putting
far as
syringes on them.
identifying them.
No, sometimes they look very similar. A lot of times they are labeled as hemodialysis catheters, but sometimes they look very similar. So it's just something to ask.
Yeah, that would be one of the early questions to ask them, wouldn't it?
Mm-hmm.
Is this a hemodialysis patient?
What
Yeah.
type
Not
of
sure
patients
that's
would
gonna be
even have,
something.
I mean, only the dialysis patient?
The dialysis patients are the ones that are going to have a
One of my wife's
hemodialysis catheter.
daycare kids had sudden onset renal failure, and he had dialysis.
Yep,
So this is a perfectly normal kid.
Parent,
right,
that would,
right.
has to be one of the first things.
Right.
That they
I mean, my wife's daycare kid had a perfectly normal kid that went in sudden onset renal failure, and he went home with was doing dialysis for like a month. So, but he was at home, so You could walk in the door, you wouldn't know it's wait a minute, he's got the line sticker.
That would be the only one that you don't touch, would be a hemodialysis
We
catheter.
were just discussing, that's probably not gonna be the first thing they ask.
No, but most patients that have hemodialysis, that's gonna be one of the first things that they tell you.
Right, and that's what.
Is that-
Their
That, you know,
caregiver,
they
parent
get
would
dialysis.
probably
That
be
should ring
on
a
top
bell,
of that.
yeah, and if.
And I don't think they would probably access, it would be more of if it didn't clot off after and it's bleeding.
Or-
They're,
Pulled over,
using
yeah.
pressure to.
Okay,
Yeah.
it's good to know.
I mean, really, most of, you know, from an infusion standpoint, the biggest things that I see would be, you know, an infection, like that's led to sepsis, and you've got a patient that's crashing very quickly. You know, you could have superior vena cava syndrome. You could have, I mean, another common one that you could be called to would be an adverse reaction to a medication. But,
Okay.
okay.
Then,
Thank you.
I think what would be way cool is if we move this table back, and then you guys come around and practice disconnecting and connecting and, you know, identifying, we have a split port on a double lumen thing, you know, just kind of maybe even pull out a Mickey and put it back in or something, just to play with it while we're here and say, you know, when you're teaching, that might be something you want to do.
Did you put a port in?
There's a port
so I
right
could
here.
Try to access, okay.
There's a port right here.
Now-
Now, this is a small port. This is not uncommon to see this small of a port in our smaller peds patients, like our babies or our toddlers. They're not all that big. So you have a lot smaller port, because if you look at this under here, it's a much smaller port. So you got to get right in the middle of that septum. But that's why when you do it, you stabilize, like I stabilize with 3 fingers, not just 2, because if 2, you know where you are there, but you don't know where you are here for the middle. So if you stabilize with 3, kind of make a triangle, you know exactly right where that middle of that port is.
The
And you
kicker
guys can practice in the
is-
box too if you want to practice.
Yeah, I
The
think, yeah, I
kicker-
like that, that's
Yeah.
kind
The
of neat.
kicker thing though is
Understand.
that needle is down right now, right? If you
Yeah.
lift that needle, if you open a needle this way, like it's supposed to when you take it out, I don't think you can get it put back down,
No,
right?
you can't. So
If
this
you
is what it
o-
looks like
if you
when
do
it's
that,
access. It's a safety needle, so when we
Oh,
get to
right,
pull it
yeah.
out, we pull it all the way so it clicks.
Oh, okay.
And then it can't go back in and it can't poke you, it can't poke the patient.
Sure,
So, yeah.
just be aware.
but you can't get it back out if you want to practice.
Right.
Oh, yeah,
That's-
we got you there,
Yeah,
we've done that.
So, why don't we do this? Why don't we play with this stuff for a while? Then we'll take a little bit of a break, so I can transition the table. Or maybe what I'll do is set up my
You
stuff
want
on
to
this
just set up on that table?
You know what? Watch out for your line there. Okay. And yeah, I'll just move this table back. You guys can take that. and-
Was that helpful?
Yes.
Trainers, I know I
I
appreciate
was
when
thinking that.
I do a
I'm
lot
like,
of
I
classes,
wonder.
but I never get contact.
This'll cover my peds.
Okay, and I want to talk about some trach information, give you some information about tracheostomy tubes and emergency stuff, and just making sure everybody, okay. Tracheostomy tubes are not just short endotracheal tubes, okay? Or, you know, how you guys secure your airways up here, tracheostomy tube is not just a short one like that, right? So I want to talk a little bit about that, different types of trach tubes, and I'm going to be sending you with this, but we have a little neonatal trach tube, okay? We have a pediatric trach tube, and then we have an adult, and this adult is actually a double cannula trach tube. Right, so you might see all of these. You can see it obviously in adults. You're not going to see that in the pediatrics. And then we have this thing called a flex trach tube, which is not unlike a regular trach tube, but it just has that extension on there. So I have actually this mannequin I have has the flex trach tube in it because we're starting to see that become more and more popular with our pediatric patients. Just allows some mobility when they're moving around on a vent. This is representing a ventilator circuit. So I'd be going back to the vent with a temp probe, okay? So the endotrache, or the tracheostomy tubes are gonna be something along that line. The airway anatomy, you all are so used to accessing this way, you may not be able to access this way. I mean, some of our patients are trached and they have a perfectly good access. I have a lot of patients who can talk and eat as well as I can, you and I can, but we have some patients who have complete tracheal diversions. So if this fails, you don't have the opportunity to mask ventilate or put an artificial airway in this way, right? And the family is not going to know that. Okay, they're not. you might know, but you're the exception to the rule. She's very, very good at what she does, but some of our families may not understand that you don't have that upper airway. The other thing is when we suction paper, when we tell people to suction, do your staff suction airways this way if they have to? Okay, you guys are putting some sort of,
So the first responders, we have the VBAC.
okay.
That is our
Okay.
suction.
So how far down do they go down? When they, or just, it's up here?
It's just oral pharynx.
okay.
And then there is a flexible tip, but then they measure from around the nose
Mhm.
and then down to the xiphoid process.
Okay, and that could be very, very dangerous to our patients. All right, most of the time, our patients are going to have what's considered, I'll be giving you this as well, they'll have this in the home. All right,
Oh.
they'll talk about the size tracheostomy tube, the size suction catheter they should use, and then what's called the safe suction depth. And usually, safe suction depth to our pediatric patients is just going to be to the distal end of the trach tube.
Sure.
Because if you extend it down like that, you can cause pretty severe tracheal damage. To every rule, there's an exception, except for that rule. Okay, that's the last step. If we cannot get an airway opened up at all, then we might ask you to go deep suction. Okay, but most of the time when we're talking about suction, we're only going to the distal end. So most of the pediatric suction catheters are going to have measuring marks on there and should be illustrated, or they should know how far down to go. Okay, be aware that they may have a flex trach tube like this, and you'd have a specific depth for that flex trach tube, so it might be this. But if we can't get this trach tube in, can't get it in, at some point they're going to go to what's called a size smaller. The size smaller may not be a flex, so this suction depth could be way too deep. Right? That's why we talk about under say our trach tube, our primary trach tube, safe suction catheter size and suction catheter depth. But if they had to go to the smaller trach because you couldn't get the regular trach in, well, the suction depth might be different than the primary trach. Does that make sense? So, just trying to avoid tracheal damage to the airway is kind of important for our patients like that. So that's the obstructed airway. Bag mask may not work for a lot of our trach patients. Just be aware that if the trach tube pops out, we need to get a trach tube back in. Most of our patients, we can get a trach tube back in. I can count on one hand with fingers left over the last 30 years that we haven't been able to get a trach in. Okay, and we'll talk about that again in just a little bit. Does that make sense about some basic sizing? We'll talk about the infant, the pediatric, a flex pediatric, and then the adult. And then the adult could have a double cannula, and all of these trachs may have a cuff or a balloon on there, and I'll talk about that again in just a moment. All right?
Even the baby ones?
Possibly. They could have what's called a TTS, or tight tube shaft, and a TTS, or tight tube shaft, means there's a cuff. Oh, I need a syringe. A TTS, or tight tube shaft, means that when it's deflated, it has the same profile as an uncuffed trach, but you have the pilot balloon, and then when we inflate it, there's your cuff. Okay, but then when it's deflated, it's like that. The vast majority of our pediatric patients have this style cuff, but the vast majority of the adult patients have this style, that when it's deflated, it looks like a shriveled up balloon. Well, this one takes up a lot more space in the airway tunnel than this one. Does that make sense? So, we could have children that have uncuffed trachs, or we could have patients that have cuffed, but they may not use the cuff unless they're having difficulty in ventilating. Okay, so minor or little things like that. That's kind of what I want to talk about on the airway anatomy part. Emergency bag, emergency bag, emergency bag. Everything you need for an emergency is in here. Right? And they should not leave home without it. That's more important than an American Express card. Okay? We even tell people, if you're going outside to go in a swing set in the backyard, you better have this with you, because everything you need for an emergency is going to be in here, including, well, let me do a fun little experiment. Hand me the red mesh bag. How easy is that to find? Everything you need for a trach emergency is in here. And we put it as a red mesh bag on purpose, so somebody like yourself who's never seen this before can find it. And in this red mesh bag, we have a little description of everything that should be in here, which is in here. So you're gonna have, well, we have, I'll come back to where I can get the camera view, sorry. This red mesh bag is gonna have your trays, okay? Well, this one is an example of a flex tray in here, but the half size smaller is a non-flex tray. So they may be different, but a half size smaller is labeled, so you know what size suction catheter and how far deep you go down, right? So if I was gonna do an emergency tray change, I'm gonna grab the larger of the two trays and put that in. Okay, and we'll talk about that in emergency tray change in just a moment. Okay? So that's part of the red mesh bag, and then of course all of the other tools that you will need. Some suction catheters, some scissors, Kelly clamps, some securing devices to tie a trach in place, Surgilube, saline. Some of our patients, instead of having a Velcro trach secures or the 12-tape spring, could have a beaded chain. And it's just an alternate way of doing it. So that's why they would have a wire clipper, so they can clip that beaded chain. So all of those things, or this type of thing, are in here. We direct staff to check this every shift. They don't do that. Okay, our staff do, but they don't do that. You know, so I've gone and done safety checks in a home, and I have found that a box was empty, and I found when both boxes are the same size, where the big trach was put in a small box and small trach in the big box. Right. So be aware that. I always tell people they can never trust the person sitting next to them or across from them for leaving them with functioning equipment. So the staff has to check.
Yeah, right.
And so my guess is you guys have to go through a safety check on your rigs, right? Yeah. Okay.
Yeah, and then you'll find if you don't check one particular item out and then you feel yourself needing it, you will never, ever again forget that piece of equipment.
True, but you don't want to find that situation.
12-leaf tables are very important to
But
go
it
to
happens,
Catholic, unfortunately.
So if you're called in a situation where this patient's having some sort of airway emergency or whatever, one of the things or if they have to transport, you absolutely want to make sure that they have their emergency bag and everything that, you'll be able to dissect this, you know, at your leisure, but you'll be able to find all this stuff in here. And it also talks about emergency airway, you know, what we call BIBS, bag irrigate bag suction. I'll talk about that again in a moment. So the red mesh bag is super, super important. So they always have their primary trach and they always have their half size smaller. They're also going to have home suction equipment. Now this is a stationary or a portable home suction device that we're going to send with you guys. And it may or may not be what they have. They may have stationary, but like that. Now this one happens to be battery operated and travel with this because the batteries are notorious for failure. And then they would also have a 12-volt power option in there, right? And you guys will be able to take this back, in the interest of time, you guys will be able to take this back, take it apart, put it back together, adjust it, you know, play with some suction. On my little sheet, I talk about a safe suction pressure. You know what, if they're calling you guys, get suction, right? And I'll pretty much guarantee these machines are not going to be as strong or as reliable as what you might have on your rigs, okay? But it's going to get you from the house out to the rig. Right. Do you guys have a portable suction device?
Yeah, the handheld, they're horrible.
handheld are horrible.
But in the ambulance, we have, you know, on,
You have
without
exactly,
onboard.
exactly.
You know.
But you don't want to use adult suction pressures on that, probably maybe
Right.
about half that.
Yep.
Okay, on that. And then the suction devices that you could have, well, they may have just a mouth operated. Okay, something just to clean out the mouth, okay? They may have a sleeved catheter. I love these things. Because a sterile catheter, when you open these up, gloves don't fit me. Okay, so some of your bigger handed firefighters or EMS people can have this and they can extend it to whatever depth they want and suction like so. Okay? Does that make sense? So this is called an inline suction, or excuse me, this is called a sleeved suction catheter versus a standard, where you'd open up, put on a couple gloves and put on a cap.
And that's the only reason for the sleeve, is to protect it.
Actually, yeah, the sleeve is there to protect the catheter because some of our patients are going to reuse their catheters. So they might be a brand
Oh, I see.
new open section, you know, open up
Sure.
a brand new one every time, but they may have a sleeve catheter, they'll suction and reuse it, and suction, reuse it, suction, reuse it. So they may show up in the home and see this in place. That's fine. Okay, like I said, I really like these things. I always tell people non-sterile gloves, but these work really, really well. Right? Well, don't get that confused with what we're seeing more and more of, and this is called an inline suction. Now, when I want to suction a patient, I have to disconnect them from the device. I have to suction them out and reconnect them. But with an inline suction catheter, this is hooked on, my vent is hooked on, and then my suction is hooked on.
No, but that means they're never without air.
Yeah.
Okay, so now what I can do is I can advance this down to what's called a safe suction depth, and we always measure it right here at the hub. You advance it down to whatever color it's supposed to be at. You squeeze that, so like putting your thumb on the suction port, you squeeze that and you can pull it out. So it's called an inline suction catheter. So you may arrive in a home, so not only do you have all these infusion therapy things that Jill was talking about, and a G-tube and a ventilator circuit, now you have a suction catheter hooked on too. Okay?
Which I would
Possible.
utilize.
And then what you
wanted to show them that you gotta turn that to make it suck.
You mean, yeah, this is like that. I squeeze that to create the suction, which is the same thing as putting my thumb on the suction port here. Okay, but this can be turned like that, which would lock it. So if you can't get the suction, you have to turn that and create the thumb. Okay, so sometimes they'll lock it and unlock it every time, and I've found it in the home. Oftentimes they just leave that open because they don't have continuous suction like in hospitals. So, along that line. This little tail would be for a saline valve. You could just twist open a saline valve and put it on there. Well, guess what? I would have a saline valve in my e-bag. Okay, twist that open. And then you could put that on there and you could squirt some down to lavage, and you can also squirt that down and suction at the same time to rinse it. Okay, I'm not going to put it gets really sloppy in here when you use that, so we'll empty one of these out for you, but you get the idea of what that's all about. Okay, so those are suction devices. They might have an oral thing. Okay, they might have a regular suction catheter with gloves, and I gave you some extras of those in there, and they may have a sleeved catheter, or they may have the inline catheter. Now, in a big hurry, you're going to use an ambu bag. You're going to be taking this off, so you don't have a suction on there. So you have to switch to one of the other suction catheters. Does that make sense so far? So that is home suction and home suction devices. All right. Well, if you guys are going to work with a patient, oftentimes you have to use an ambu bag or manual self-inflating resuscitation device. Ambu is actually a brand name. Like Kleenex is a brand name. So in the home, they're going to have one at their bedside, and they're going to have one in their e-bag. Now the e-bag one might be compressed or squeezed together, and you might have to extend it like so. We have the big pediatric bag, or we have our itty-bitty infant bags. We have a pediatric bag, and we even have adult bag, which is the size of a football, very similar to what you have. You can ventilate a very, very tiny baby with a small bag. You guys know that. But you can't. It's probably better to have a bag that's too big than too small, is what I always tell people. Okay? We always put these little flex pieces on here because when you go like this, it's a 15 millimeter adapter. So all trach tubes are the same size right here. That's a universal fit. And all ambu bags are going to be able to fit on all trach tubes. That's why you could use an adult bag and an infant, because that's the same size. Okay. What we like to do is put this little flex piece on there. This is actually a safety cap, and the safety cap keeps it a sealed system. So if you're going to use it, you just yank that off, and you put this on, and now it allows you some flexibility when you're doing that. Does that make sense? If you were going to use oxygen, what's your guidelines for, if you have to bag a patient with oxygen, how much oxygen to use? Crank that sucker up as high as it will go.
If they're in cardiac arrest, it's 4 liters.
Pardon?
In cardiac arrest, it's 4 liters.
Okay, we tell people at least 5 liters for children, 8
Normally
liters for
it's
adults.
15.
You know, if they want to give 100% oxygen, at least 5 liters for children, 8 liters for adults. Crank that up, okay? But like that, and then you have the oxygen reservoir, works the same, okay? The difference between a pediatric and adult bag is the pediatric bags are going to have this little pop-off valve right there. So when you will close this with your finger, it's releasing out the pop-off valve. So you might have to override that to go like that, okay? Just be aware of that. The adult bags, I'm not sure your adult bags are gonna have pop-off valve or not. And it's, so if you did that, if you applied too much pressure to a little kid, you could have a problem, okay? But you could, with your finger, put your finger over there to override that if you had to. And I've seen that in some asthma kids and stuff. In the past. You're giving me a
I
look.
know, I can't remember either. I don't think
On
so.
the adults, I think we do.
You know how you can check?
I don't,
You can check with your adult, put your thumb right there and squeeze. If you release, you have a pop-off valve. If it's solid, you don't have a pop, okay?
I have it in my car.
So we're gonna have the 50 millimeter adapter. We also encourage for patients who have an airway is a mask. So if the rare occasion you can't get this in, they should have the proper size mask, right? During your training, this can be filled up with just a regular lure syringe. You can just add more air onto that if you need
they're
to.
pretty fluent in big valve mass ventilations,
I'm sorry?
and they're pretty fluent in
Sure.
BVM.
But it's
seals
exceedingly
are-
rare that you would mask ventilate somebody with a
Yeah.
trach.
Okay.
You know, the only time you mask ventilate somebody with a trach is if the trach came out, you can't get it back in, then you might mask. But if they don't have an airway, that's not gonna work, so you have to get that in there.
And the only reason why you wouldn't be able to get one back in is really just a spasm of their.
The worst one I ever
Trach
saw with
behind
this
there.
kid had a very, very reactive stoma site, just boom, would just seize up like that. And one time they ended up having to put a suction catheter in there to keep the airway open while they transported him in. Luckily, he could breathe enough this way. You know, that was very, very lucky. And actually, the ENTs couldn't get the trach in. They had to put him under anesthesia and do it again. That's very rare. The other time I've seen where you have difficulty getting a trach in is that they just went to a larger trach. So now you have a bigger kid just got a bigger trach. Well, the first time they try and do a trach change, or the second time they try and do a trach change, they might not be able to get the new size trach in. So then they panic and they call you guys before they try to half size smaller. I mean,
Would you ever suction a stoma before
Open
you
stoma?
before you reinsert a trach?
no,
Just
I
to
get
make
that
sure
trach
it's
in there.
clear, or
I
when-
get that trach in there. When
Okay.
you pull this trach out, you put the new one in right away.
Okay.
Yeah, so suctioning an open stoma, the problem with suctioning an open stoma is you're probably not gonna make the curve. You're probably not gonna get it down, and you're gonna go right through the back of the stoma.
Okay.
Or right through the back of the trach. So we used to preach that, but we've long since gone away from that no, we're not suctioning the open stoma, or it's exceedingly rare. And you know what, they're not, if they're used to doing that, they're not calling you guys. You know, there's something much beyond that, okay? And then this is the main reason I wanted to show you why you want to use a regular ambu bag, or the patient's ambu bag, is what's called PEEP, positive and expiratory pressure. A little bit of air we trap in the lung, keep the micro airways open. So I think I've explained it once, where you blow up a balloon, you let the air out, the balloon goes floppy. You blow up a balloon, you let it out, it goes floppy. How about if we blow it up, we let the air out, but we trap just a little bit of air in the balloon to hold it open? That little bit of air that we're using to hold that balloon open, that's PEEP, okay? You and I have anatomic PEEP, where our body kind of closes our airway and we keep a little bit of air in our airway. Well, when we have an open stoma, those microscopic airways called the alveoli start to close off, called atelectasis. All right. So what PEEP will do is, if I inflate and deflate, you see how I'm trapping a little bit of air in that balloon. But if I did not have PEEP on there, I'm not trapping any air. So for most patients, that's not going to be a problem. Your patient on the street, that's not going to be a problem. But for most of our long-term vented patients, they have PEEP set on their ventilator, and if all of a sudden you're trying to ventilate them without PEEP, they might not have the positive response you want them to, right? So we want to have PEEP on the ambu bags.
Yeah, that's
I
right.
remember wearing that guy.
And I'll be sending you this, okay? So then you squeeze like that, but you need the PEEP on here to match the PEEP on the vent.
It's like CPAP.
Because if I twist this down way like so, watch what happens. That's a little bit too much
Not
PEEP,
good. Yeah.
okay?
Looks
But on the
bad.
other hand, if I open this up all the way, so I don't have enough, well, then they may not be trapping enough. Or, as I said, with your bags, you don't have PEEP, and that could be very problematic for the patients. That's why I strongly encourage, if they can, to use the patient's resuscitation bag with the PEEP valve and make sure the PEEP is set with proper value. That makes sense?
Yeah.
You give me a look.
Yeah.
No, I'm just trying to imagine what ours look like. That's all. Our ambu bags.
And during your training, you can show them the difference of, use your bag, and you get this, and then use this, and you'll see the PEEP, and they'll think, oh, hopefully it will work. I can show you a really, really good video, I'll forward it to you, email of what happens so long as it doesn't have PEEP, and then they start adding PEEP, and it shows it's a pig model
Neat,
that they
yeah.
use, and it's really cool. It's really visually informative, okay? So that's kind of the manual resuscitation bag, right? So for a trach emergency, the acronym we like to say is called BIBS. And BIBS is bag, irrigate, bag, and suction. And it's going to be on here, all right? So I'll be giving you a copy of this. Okay, actually you'll get 2 copies because you have one in your red mesh bag, and then you'll have another one for training, all right? And the same thing is more of a flow chart this way. So if your people are in the flow chart, I don't like flow charts. It takes me too long to read them, okay? But this one, so different learners have different